Hello. Hi, we're going to get started. Welcome, everyone. Thank you for joining our breakout session, Equity Rounds, an opportunity for clinical and anti-racism learning to intersect. We're going to get started with just brief introductions. There we go. I'm Dr. Kelly McGregory. I'm a pediatrician at the University of Wisconsin School of Medicine and Public Health. I lead the Division of Child Protection, and I'm also an Associate Program Director for the residency program.
I'm Laura Hauser. I'm a general pediatrician at the UW East Terrace Drive Clinic, and I'm the Director of Advocacy for the department. I'm also a member of our Global Pediatrics Division.
Good afternoon, everyone. I'm Mala Mathur. I'm a general pediatrician at the UW Health 20 South Park Clinic, and I'm also Director of Professional Development for the Department of Pediatrics.
Hello, my name's Mary Ehlenbach. I am a general pediatrician in the Division of Hospital Medicine, and my clinical work is in the Pediatric Complex Care Program. And I'm also the Director of Diversity, Equity, and Inclusion for the Department of Pediatrics.
Hi everyone, my name is Jenna Contreras. I'm the Strategic Initiative Specialist in the Department of Pediatrics, and in my role I get to support the directors of strategic initiatives like Laura, Mala, and Mary in all of the exciting things that they get to plan and do.
Thank you. So our learning objectives for this afternoon are to strategize opportunities for creating an educational discussion with your group, team, or department that facilitates confronting implicit biases by exploring concrete examples of racism or bias that impede justice as experienced by those you serve. Also, to appraise how historical racism and other forms of bias impact the current experience of those from historically marginalized groups. And lastly, to propose incorporation of anti-racism techniques into forums that already exist in your work environment. Before we jump in, we would like for you to fill out a brief pre-survey. It'll only take a minute or two, and it'll help us understand where we're all starting in this work. Please use the Q&R. I see some people finishing. We'll just take another minute. And if you can just let me know if you're done or if you need more time. Not if you're done? All right. Thank you. We'll move on.
Yeah, some of us are technologically primitive.
All right. So why are we here? We are here to address and work to provide more equitable opportunities to those we serve. The Department of Pediatrics is committed to addressing equity within the department and for its patients and families. One way we are doing this is through Health Equity Rounds. Health Equity Rounds was started at Boston Medical Center by pediatric resident trainees. They recognize a need for a meaningful way to engage faculty members and learners at all levels in discussions about the impact of implicit bias and racism on patient care. This is a great effort in educating our faculty, staff, and learners within the department about how racism and bias can come into play. There are many ways to address equity within the workplace. During this session, We will work through an equity rounds framework to show how the Department of Pediatrics established health equity rounds. Health equity is defined as the opportunity for everyone to attain their full health potential, where no one is disadvantaged from achieving this potential because of their social position, like class or socioeconomic status, or socially assigned circumstances like race, gender, ethnicity, religion, sexual orientation, or geography. Your work may not involve care with patients, but the principles highlighted in health equity rounds can be utilized in other work settings. As we guide you through the framework, from our health equity perspective, consider how you might apply the framework in your work environment. During this session, we'll go through our roadmap together. This is a workshop, so we want you to participate. We'll start with motivation. We are motivated because bias can have a negative impact on patients. Then we'll go to planning. We'll discuss how we establish the team and structure for health equity rounds. Then we'll move to didactic instruction and discuss essential elements to enhance knowledge. Then we'll move to emotion. We'll discuss the importance of providing time for reflection. And finally, we will discuss the opportunity for building skills. Let's take the next 5 minutes to work on the motivation section of the framework. Use this time to brainstorm ideas by filling the fillable PDF, which you should find on the breakout sessions page on the diversity website. And there should also be a link put into the chat. Okay. The fillable PDF will have the questions that you find on the screen also. We want to identify, are there areas of bias in your division or workplace? How can bias be manifested in your work environment? And the second thing is to think of an event, identify an event, something that has occurred in your division or department. The strength of health equity rounds stems from identifying an actual event or occurrence in your work setting. Is there an opportunity for learning? Is everybody finding the framework, the PDF? Okay. Is anyone need more time? No? Ready to move on? Not yet? It's not quite been 5 minutes. 1 more minute? Okay. Jenna says we have 1 more minute. She's our person who keeps us on schedule, so. All right. So please use the QR code on the screen, and in 1 word, tell us what is the root of your motivation. Please type your word once you click on the QR. There's a place to put it there. These are great. Keep them coming. Oh, this is great. Thank you for your participation. It looks like fairness, love, empathy, equity, lots of great words here. Thank you. I wonder if we can capture this word cloud some way to my IT friends in the back. Thank you.
So, to help you understand how equity rounds is done, we'll describe a patient case on which we based our first pediatric health equity rounds. The reconstruction of the event is based on documentation in the medical records, but identifying factors have been removed. Our patient is a 2-year-old black female who was generally healthy, but then started having trouble breathing. One day, she woke up from a nap, and her parents noticed that she had hard and fast breathing. They called 911. When she got to the ER, the medical team put oxygen on her to help her breathe, put an IV in, gave her fluids and antibiotics through the IV to treat her for dehydration and potential pneumonia. She was admitted to the pediatric intensive care unit at our children's hospital. Fast forward to the next morning, and our patient was doing better. She didn't need as much oxygen. The pediatric radiologist looked at the x-ray that was taken and didn't see any bacterial pneumonia, but rather signs of a virus causing her symptoms. She'd had a nasal swab done that showed parainfluenza 4, which is a common cause of a viral cold that can cause cough and trouble breathing. When the medical team in the intensive care unit did their rounds that morning, they decided to stop our patient's antibiotics and potentially discharge her home later that day if she continued to do well. When the family heard the plan, they were very concerned that their child, who had been sick enough to be in the intensive care unit, was going to be sent home so soon. The medical team asked the social worker to address this conflict. The social worker reached out to the hospital's patient relations team, who recommended that the doctor and head nurse meet with the family in the presence of the hospital security. After that meeting, our patient was moved to a different room in the children's hospital outside the intensive care unit. She stayed overnight that night. She continued to do well and was sent home the next day. I'd like to emphasize that the hospital security guard was present in the patient's hospital room when our patient's parents were told that she was going to be transferred out of the intensive care unit. To revisit the framework that Dr. McGregory introduced, we saw that there was racial bias influencing the way we care for patients. We chose this case that I just reviewed as the event to highlight for our health equity rounds. Next, we'll go over the planning process of our rounds. Our planning committee was assembled using a Qualtrics survey that was sent out to the members of our department's IDEAA, Inclusion, Diversity, Equity, Accessibility, and Anti-Racism Committee. It was then posted in bi-weekly department newsletters until we had a full team. Faculty, staff, residents, and fellows were all represented on the team to include a wide range of work experiences. Jenna Contreras was our organizer. She took charge of keeping meetings, plannings, and resources on track and organized. Because of the size of the planning committee, we found it helpful to have pre-meetings with smaller groups of key personnel before the larger committee meeting. That way, we had time to think things through before presenting to the group, rather than trying to brainstorm a plan with up to 15 people. Our department's professional development team was instrumental in the planning and implementation of this event. Finally, we were fortunate to have the full support of senior leadership within the department, including our department chair. Without her visible buy-in and participation in equity efforts, this work would have been much harder.
Okay, so I just kind of wanted to pick up from there and talk a little bit about sense of belonging at work. And I think that was something that people put on the word cloud, is that sense of belonging, and why we're here. So just to take a step back and contextualize why we're talking about creating these equity rounds for our workplace, I think it's really about creating a culture of equity, but it's also about creating a sense of belonging at work. And according to research, about 70% of what makes people feel like they belong is what their leaders say and do. The more people feel included, the more engaged they are in work and are able to collaborate and really lift up the performance of a team or a department. So what helps people feel that they're treated fairly, valued, and have a sense of belonging? It's really about the organizational's mission, policies, practices, coworkers, and of course, the leadership. So just to talk a little bit about inclusive leadership traits, when we think about traits that inclusive leaders have, we think about having a visible commitment to diversity and really having the courage to challenge the status quo, hold others accountable, and make diversity and inclusion a personal priority. We also see leaders that have humility, that are able to admit mistakes and create the space for others to contribute. Inclusive leaders also have awareness of their biases and personal blind spots, as well as flaws in the system, and really work hard to ensure that things are fair. Also having curiosity about others, being open-minded and having a deep curiosity, listening without judgment, and seeking with empathy to understand those around them. In addition, inclusive leaders have cultural intelligence by being attentive to others' cultures and adapting as required, and also fostering effective collaboration.
So empowering others, paying attention to diversity of thinking and psychological safety, and focusing on team cohesion. And I would argue that these leadership traits are part of the professionalism that we all need to embody in being part of a team. So in the Department of Pediatrics, we have a weekly conference called Grand Rounds. It's a time-honored process through which physicians teach and learn from each other. This is a lecture-style presentation given by a content expert within the department or from the larger university or from an outside speaker. And these conferences happen predictably throughout the year on Thursday mornings. In the Department of Pediatrics, we are currently holding these conferences virtually with fairly good turnout, consistently having over 100 participants at our virtual Grand Rounds conferences. And I think it's really important to think about as you adapt an equity rounds to your own team or department, to think about holding these in a framework or a departmental conference that gets a lot of participation, where people are predictably going to attend. And this ensures that the equity rounds can really reach the most people and is most impactful. So just a little background on where this came from. Health Equity Rounds was started at Boston Medical Center by pediatricians in training in 2016 who recognized a need for a meaningful way to engage faculty members and learners at all levels in discussions about the impact of implicit bias and racism on patient care. And with the support of the department chair and residency leadership, they developed longitudinal case conference curriculum with a focus on discussion, reflection, and developing solutions. So they had a case-based educational presentation using a clinical encounter and applying an equity lens. Then there was an opportunity to review objectively the role of implicit bias and structural racism in that healthcare encounter, and then also how we can provide the best possible care to our patients and families in the future. And that intervention would really enable participants to recognize health inequities and identify tools and skills that can be utilized in the future. So in October 2021, Dr. Andy Asnes, an outside speaker from Yale School of Medicine, presented at our pediatric Grand Rounds. And during her presentation, Dr. Asnes introduced Health Equity Rounds to our department and met with a smaller group afterwards for more in-depth discussion. And inspired by this, we sought to bring Health Equity Rounds to the University of Wisconsin. So the goal of our Health Equity Rounds were really to identify and analyze the effect of implicit bias and structural racism in clinical scenarios, to describe the historical context and present-day role of structural racism and its impact on the healthcare system, to employ evidence-based tools to recognize and mitigate personally held implicit biases, and to use newly learned strategies to combat structural racism at the institutional level and reduce the impact of implicit bias on patient care and interprofessional relationships. So now we're going to continue on our framework roadmap, and after hearing a little bit about how we planned our equity rounds, we're now going to turn to our worksheets and reflect on how you could plan an equity rounds conference for your own department or workplace. So I'd like you to look at your worksheets and fill out the area under the planning section, where we're going to work in the next 5 minutes about identifying a core group of equity champions in your workplace who have an interest in this work, and identifying one person to keep the group on track to act as an administrator. The second thing I'd like you to reflect on is identifying an inclusive leader who can support this work in your workplace. And also identifying a possible setting for equity rounds, whether it's a routine department meeting that already exists or it's a professional development session. And then also think about how you can organize your materials, deciding on a central online location where materials for this conference can be stored for the planning committee. For example, UW-Madison Box or Google Drive. So I'm going to pause our presentation for about 5 minutes so you can reflect and jot down some notes at this stage. We have about 1 more minute left. Okay, are most people done with this part? Can we move on? Okay, perfect. So I just wanted to kind of recap where we are on the roadmap to creating an equity rounds. So we developed our motivation, identifying areas of bias, perhaps identifying an event, and we just started our planning session. So establishing our equity champions, identifying inclusive leaders, identifying a setting and format, and organizing materials in a location that is accessible to all. And we're now going to progress to the didactics of the conference and how this can be framed through a historical context.
Okay, here we go. All right, so because our health equity rounds was based on our hospital calling security about a Black family, we wanted to evaluate, oops, sorry, wrong slide notes. Let me try that again. Okay. As in all didactic presentations, it is crucial to create and share learning objectives to ground the learner. And so for our health equity rounds, we used the 4 learning objectives you see here, which we thought were key perspectives and take-home points that were critical for our audience. And so specifically, we wanted to make sure that folks were analyzing the responses that healthcare teams have to clinical encounters involving Black patients and families. That's our first one. We wanted to evaluate why responses from Black families are perceived and responded to differently by the healthcare team compared to families of other races. We wanted to discover why security is more likely to be called on Black patients and families. And then finally, we wanted to examine how using a trauma-informed lens can facilitate positive and equitable outcomes. And I don't think we mentioned it earlier, but we chose the title Seeking Security for our health equity rounds, which we thought was encompassed the perspective of many folks. There we go. So this slide and the following 2 slides are actually taken directly from our health equity rounds presentation. And one aspect of our didactic instruction that we thought was particularly powerful was the comparing the perspectives of the physicians caring for the child, which you'll see on the left, with the perspective of the social worker, which you'll see on the right. And as you can see in the documentation from the medical record, the physician team painted the family in a much more negative light, while the social worker's documentation took a more neutral tone and could even be interpreted as being more understanding of the family's perspective. Presenting both of these perspectives in this way helped our audience to understand the path that led the physician team to call security, and it also reminds us how focusing on a single perspective can be harmful to those we serve. We then shifted our didactic instruction to provide some historical context about the justifiable mistrust that some Black families have about the American healthcare system. We felt it was really important to include this information in our presentation because it helped to root the events that transpired in this case. We really wanted to emphasize the point that this event of calling security on a Black family was not an exception to the norm, but one in a series of a long line of health inequities. And this is the point in our presentation when we really highlighted health equity as the equity principle. Okay. And now, because our health equity rounds was based on our hospital calling security about a Black family, we wanted to evaluate if this event was common or uncommon at our institution. We had some hypotheses, but wanted to see if we could get some objective data. So we actually consulted the hospital security team to learn what type of data are collected about the security calls that they respond to. And we learned that our hospital does not yet collect data about the race or ethnicity of the patient or family when security is called, which revealed an area for growth. We then examined the medical literature to see if other institutions collect racial and ethnic data about their security calls and learned that other institutions do, in fact, collect this type of data, and some have actually published their findings. And not surprisingly, in the medical literature, there is demonstrated to be a higher likelihood that security will be called about Black patients and families than those of other races. So we took some key tables, salient tables from the medical literature and put them in our presentation to help our audience understand that events like this do not occur in a vacuum. And then finally, we rounded off our equity rounds with an engaging panel discussion. So we were very intentional about the folks that we chose to be on our panel so that we could showcase a diverse set of perspectives. Our panel included social workers, an established pediatrician, a pediatric trainee, and leadership from the UW Health and School of Medicine and Public Health DEI office. One mistake that we made that we hope you can learn from is that we definitely did not dedicate enough time to the panel discussion. Our session went by far too quickly, and it would have been great to have had more time for our panel to talk through some of the questions from the audience. So back to our framework. Now that we're back on our roadmap, as you develop your equity rounds, this portion of the framework may need to wait a little bit until you have your equity champions identified and engaged in the work. But just remember to come back to this section at a later time to start planning. And we found it was very important to establish those learning objectives, highlight perspectives, identify a concrete equity principle that could ground us, and then involve subject matter experts as well. And in the next stop on our roadmap, we will share lessons learned about addressing well-being when hosting equity rounds.
Tending to the emotions of your audience is essential in delivering an impactful equity rounds. Conversations about equity or racism bring up feelings of fear, anger, distrust, and sadness, so acknowledging different life experiences and backgrounds can help build a common understanding among your audience. We use this slide in our presentation to set ground rules for the session. We communicated our expectations of the participants, protected the identities and intentions of those involved in the case, and provided the resources for a common language. The glossary referenced on this slide, which was provided to our department members, is the same one provided to you at the bottom of the framework worksheet on the Diversity Forum website. Setting these ground rules before diving into the case helped give structure to a topic that can often feel intimidatingly large. As Dr. Ehlenbach mentioned earlier, we tried to highlight the differing perspectives of the care team and social work team to encourage the audience to think through a perspective that might be different than their own. We also gave time for our audience to think through the perspective of the child's parents compared to the care team. Providing time and space to consider different points of view helps to build empathy and establish a deeper understanding as to why people may react in a way that's different than how you would react. And in this case, the way the parent of the patient reacted to the news of their child being discharged. On this slide from our health equity rounds, we gave our audience members specific prompts to help them consider a new point of view. We also incorporated small breaks for reflection during our presentation to give the audience time to process the events of this case or memories of other cases that might have been sparked through the process of going through our patient case. Additionally, we welcomed audience members to use this time to take a step away from their computers and take a break if necessary. In another reflection slide we used in our health equity rounds, we reminded our audience that equity work is hard, and it's not meant to be comfortable. A simple acknowledgement of this discomfort can support your audience in their equity journeys. Similar to the didactic instruction section of our framework, much of the emotional work in planning an equity rounds event will have to be done after identifying and engaging your equity champions. So we'll hold off on filling in the emotions part of your framework for now as well. And we will head to our last section to address skills acquired from equity rounds and how to move forward after holding your event. So after hosting our virtual event, which garnered over 175 participants in our inaugural health equity rounds, we collected data to help gauge the success of our session and to help us plan for the future. We received an overwhelmingly positive response and some great feedback from mostly pediatricians, including comments such as appreciation for the tools to help de-escalate and considering the different ways security can be involved that may not be as intrusive to the patient or family interaction. Thinking about where a family is coming from when there is a disconnect between the team and the family, making sure that what I see as routine is still discussed with the family. Another doctor commented that they will continue to work on the way they collaborate with others, recognizing their position of power in the healthcare team, and continuing to work on recognizing their individual biases. Someone else aimed to have a conversation with their own department leaders about their practices calling security and if data is being gathered on this to determine their bias practices. And finally, one doctor commented that nothing was new, but it was so crucial to have this topic brought to scrutiny. Having grown up in the South, they felt the bias against Black patients is not implicit. It is egregiously present and accepted in Wisconsin. All of this feedback is so important for adapting our processes and improving future health equity rounds. We were and are so grateful to have received these comments and for departmental support. So after executing our first health equity rounds, our team was excited to keep our work moving forward. We identified a few additional community and department members who were interested in contributing to our work and invited them to join our planning committee. This work requires the perspectives of folks from different racial and cultural backgrounds, as well as different work backgrounds. So we continue to find ways to make all of the content of our health equity rounds as applicable to staff members as it is to the doctors in our department. We made a plan for future events and collaborated with our wonderful professional development team to solidify dates on our programming calendar. Our next health equity rounds is actually this Thursday, which is very exciting. We also have plans to provide opportunities to the trainees in our department as part of their educational training. Finally, we've begun sharing the health equity rounds framework with a few other departments within the School of Medicine and Public Health, and hope to help them build this program in a way that works best for their workplace, just like we're hoping to do with you all today. So to kind of round off our framework, in this section we addressed skills, we covered holding our event and teaching the new skills to our coworkers, evaluating the impact of our session in order to plan future sessions, and identifying relevant stakeholders to integrate into the planning committee. So one thing that we learned from our health equity rounds is that we needed more time for the panel. So we have dedicated the next 30 minutes for a Q&A session. So feel free to use the Q&A function if you're on the Diversity Forum website. If you're here with us in person, we will run around to you with microphones, but we're going to open up the next 30-ish minutes for Q&A, so feel free to ask away.
Yeah, I guess a concern I have is that there's, I think, the danger possibly of Monday morning quarterbacking, and that there's a lot of split-second decisions that might have to be made here. I mean, I can see that in a hospital situation, you might have situations, I mean, because certainly they've come up in the past where you may need a security officer present, other cases where that might not be necessary, but you have to make the decision, right, in a split second. So I guess I think that's a factor that has to be taken into consideration. Thanks.
Well, these are complicated microphones. Thanks so much for that question, and that is a point that's very well taken. If we had more time, we would have been able to show the introduction to health equity rounds that's shown at every health equity rounds, which specifically discusses that this isn't a blame or game, a blaming session. It's not an ethics section. It's not specifically, a Monday morning quarterbacking session. We tried our best to just present the facts of the case as they were written in the medical record, and asked folks to just kind of take the perspective of taking us as at our word that this was an equity issue. But I think that's really a very well point that's very well taken. Thank you.
So are there other clinical departments that have adopted something similar? And also, do you have like I'm in a research center, but also an M.P.H, and I'm just thinking about I'm really new at it in that department or in that center, but thinking about ways to translate this in terms of how to apply this, to research. I mean, it's maybe the constituency instead of, patients, but also I guess it's patients down the road, right? It's like the patient says. So anyway, any comments you have on that would be great.
Yeah, so, I think we realize that in a way we're biased because we are clinicians and talking about it in that way, but I think that there's probably a lot of different ways to take it. So one way would be, maybe specifically talking about research and was maybe like a study design or something like that biased, but then also I think you could even talk about it if you were in, say, a research lab and somehow something happened that felt like it was inequitable because of a person's background or racial identity, of being able to, kind of address that, whether that is promotions, grant funding, are there other things that aren't necessarily specific to health? We called ours health equity rounds because that is sort of the original name and what we're focusing on, but I think just equity is really the main thing. Similarly in education, I think that there are probably a lot of opportunities to talk about this in terms of equity that could get very far from health. And so I think the goal hopefully was for us to share the framework, and then hopefully in your brainstorming and with your skills and experience, you can figure out where that might best apply to incidences that you've experienced.
We've got a couple questions online.
I can add to that. Can I add to that?
Oh,
to
yeah.
this question
Yep,
too. Thanks for that question. To answer the first part of your question, the Department of Surgery is doing something similar during their M&M time, which stands for Morbidity and Mortality Lecture. And then the Department of OBGYN is also interested in starting health equity rounds. And yeah, we're really encouraging folks to think about opportunities in their workplace that to discuss equity events that are undoubtedly happening during scheduled times that already exist. Thanks.
Thank you. Megan asks, have you seen a shift in patient satisfaction scores with this practice, or employment satisfaction at all?
I think it's too early to say. This is a relatively new thing for us in our department. So I think the likelihood that we'll see an impact on patient satisfaction scores is going to be pretty low at this point anyway. But it still feels like the right thing to do. And then in terms of our work environment, I think just anecdotally, we've heard many folks mention to us either individually, personally, whatnot, that it feels good to have a forum to talk about equity within our own department.
Another question online we have is the hope or expectation to be more proactive with the rounds, or use it more as a root cause analysis event for a particular case?
Yeah, thanks for that question. I think, we are trying to identify, you know, uh, biases within individuals and structural biases. But so kind of looking at, from that perspective, where can we help change and be proactive? So it's a little bit of both. It's sort of trying to understand the situation and then making people aware of those biases and how they impact other people. So kind of giving sort of a full perspective of a situation that happens and sort of trying to understand how we might prevent those biases from impacting our work in the future.
The other thing that I think probably goes a little more to the proactive side of the question is that the Forum of Grand Rounds is sort of one of our cornerstone conferences within our department. And so people are attending because they are in the habit of attending. It's not something they're having to do above and beyond the way some of the materials may be sort of in the DEI forum of, oh, you can come to this book club discussion, or, oh, you can, join this committee. And so I think that helps because we probably get a larger audience who may not even be on their road to working on their biases yet, or not as far along the road. So that is sort of another one of the reasons, Dr. Ehlenbach said, of trying to find something that's already in existence to incorporate into.
I think too, as kind of the cornerstone of health equity rounds for our case, but equity rounds for anyone not involved in healthcare, is basing your session in an event that actually happened. So that kind of goes back to what Dr. Mathur said. It's a little bit of both of a case analysis and being proactive within your workplace to kind of change culture and change habits.
Hi, thank you so much for your presentation. I was just wondering how you solicited the example and how you made it a space where people felt comfortable sharing those examples and the anonymity process throughout. So if you could speak a little more to that, that'd be great.
So part of our steering committee, our planning committee, when we explored having the health equity rounds was, do we have a case? That was one of the questions that we asked the group. And it was a group probably of about 20 people on a Zoom meeting. So a very protected, space. And actually a few cases came up. And just for various reasons, this was the one that was chosen. And so there are other cases that we have not presented yet. Because it is an actual patient, we have to put de-identifiers in and, to protect privacy. But I felt like it was a pretty good process, and we all came to consensus for what should be the first case, and also how the case would apply to an health equity principle. And so that was really nice, the way we tied it together with the research also.
Thanks so much. My question is about your equity champions in particular, and I'd really love it if you would be willing to say more about how you identified who those people would be. And maybe related is how the responsibility for facilitating these conversations is shared. I think a challenge that's often faced in DEI work is the same 3 to 5 people in a unit are facilitating these conversations. And so I'd really be interested in more models for how to kind of share that facilitating ask.
I guess I'll start. I think when the thought of health equity rounds came to us, the idea committee was already in place, and so it seemed like a really good place to incorporate the thought of health equity rounds. So I think they self-identified, the champions self-identified amongst people who are already involved in the work, And then we also extended the invitation to others, very much voluntary. People who already have a passion for it came forward, and those who maybe wanted to, but just time-wise didn't have the bandwidth to do it. But I think we just kind of, those who were able to in that time and space, they just came forward and put everything into it.
I think one thing that we did talk about, especially when we were discussing including a learner in our presentation and in the committee, was trying to figure out that balance of not having it be like a minority tax where it's asking someone to do more work in that way and not adding stress, but wanting to have it hopefully be an opportunity that was helpful for our learner to be able to be involved in this and to have a voice without having that person feel uncomfortable or feel like it was additional work. And so there was definitely acknowledgement of that throughout. Do you want to talk about how our department chair kind of encouraged involvement?
Thanks again for this question. It's a really great one, and I think an area that a lot of folks who do DEI work grapple with. So we really felt it was important to engage our senior leadership in our department in supporting health equity rounds in order to make it successful. So we actually, I reached out to the chair of our department and asked her to please, let folks know that this was happening, that we would like her to ask people to attend, and she was so gracious and very willing to help us do that. And then she actually also introduced the session at the Grand Rounds too, and I think that was pretty powerful to see someone in a position of leadership take such interest in the work and help to bring it forward. The other piece that I'll add, just in terms of recruiting folks to help and spreading the wealth of the work to pull together health equity rounds, was it was a nice opportunity to engage folks who really didn't necessarily have a ton of bandwidth, but were interested in could envision themselves participating in this one event. And we had enough hands on deck that we were able to divide up, making the slides and those sorts of things in a way that really didn't feel too burdensome, which was really quite helpful. And then I will also just call out that having Jenna as our master keeper person, timekeeper, and organizer was really critical to the success of health equity rounds.
We've got another question online if we want to bounce back and forth between online and in-person questions. Did you have any conversations about involving other patients in the health equity rounds planning or experience and opening up the space to folks who aren't physicians or providers?
That's a great question. I think that was not really part of our initial discussion for health equity rounds. We did feel like it was really critical to partner with some of the subject matter experts within the School of Medicine and Public Health and UW Health. So we had representation from the DEI office, and they were critical in helping us plan the didactic portion and kind of framing up the whole health equity rounds to ensure that there was a consistent message across the entire, our message during health equity rounds was consistent with what the organization, the School of Medicine, Public Health, and the health system wanted to convey. So that was very helpful. I will say that now, upon reflection, I think it would be really helpful to have a community member with us in planning for future health equity rounds. That's certainly something that we're trying to incorporate in other aspects of healthcare, of having patient family representation at the table with us. So a really great suggestion and something to consider for the future.
Hi. So my question goes a little bit back to the language. I know you had talked, and I don't remember what slide, but about giving shared language and a shared vocabulary, and then presented two different points of view on the situation that was happening. So can you talk a little bit more just about what that shared language looks like, how it's presented to, whether it's the physicians and the social workers together, kind of how do you come about that language and how is it used now, to think a little bit more about bias?
Yeah, so thank you for that question. That's a great one. So from the Boston Medical Center group that created health equity rounds, there's a whole toolkit for rolling it out, and it included a glossary essentially of terms, and I think we have a link to it on the Diversity Forum page for the site, so it might be helpful to take a peek at that. So we rooted our language around that glossary, and then we did, I think at the beginning of our health equity rounds, define a few of the key terms, and then tried to use consistent language throughout the slides as well, to just try to keep that message being consistently delivered consistently. Anyone else have anything to add to that? Yeah.
As we mentioned, we ran out of time for even our panel portion of our talk, and so it was really difficult as we were planning this to figure out how much to include, because I think we were, very excited about this idea of these rounds and wanted to, do some ground setting of, let's make sure we're all using the same language, and let's make sure we all know this is a safe place and that we're not blaming, and let's make sure we talk enough about the case so that there's no questions of the medical part. And so I think that some of the specifics of expanding the language throughout our department and to our caretakers, that might not be the forum for this, at least not in our first rounds, but that is, I think, still an important piece of this work.
Kate online asks, she first thanks us for bringing this topic to the forum, and then asks, I and several other residents listening online in the psychiatry program are interested in bringing equity rounds into our department. Have you encountered any barriers to implementation of health equity rounds?
I'm not aware of any barriers. It was really embraced pretty broadly in our department. And so if in the Department of Psychiatry, if they have a few champions that they can identify there, and then they have support of their higher level leadership, I think it should be fine once you figure out which avenue you will use to introduce it. So that's really exciting to hear.
I think the only barrier is just the bandwidth of the planning committee. And again, kind of having a group that is willing to divide up the work, and then having someone who can keep folks organized is really critical. The other piece that I think that went particularly well for our health equity rounds was that we had Dr. Mathur and the professional development team engaged very early on, and they just totally know what they're doing with planning grand rounds, and so we actually leaned a lot on them for the making it happen sort of piece, and which allowed us to focus on the rest of us to focus on some of the more of the nitty gritty of the case and the didactic presentation.
One thing I would just add is that I think it's really critical to have sort of cross-pollination of different people on different committees within a department or division. So I was on the IDEA committee, but I'm also work in professional development, so it was very easy to be like, oh, hey, I know we have a grand rounds opening on this date. Let's plan for that, that kind of thing. So just thinking about, instead of having like all separate committees, but just having people who work across committees as well, I think can be really impactful.
We have a question over here.
Maybe you mentioned this. Thank you for the presentation. It gives me a lot to think about, and I'm sort of with you in a research center and trying to figure out how to apply this in that setting. Maybe you mentioned the amount of time you allowed for your session, because I know you said you ran short for the panel, but how long is the Grand Rounds meeting?
Yeah, so thanks for that question. Yeah, our pediatric grand rounds is an hour. And this being our first time presenting it, we had a lot of sort of setting the stage. And, as people have mentioned, we wanted people to feel safe, that this was a safe space to be able to discuss this topic and to, so we really had a lot of prep work to do. I think it might get a little bit easier as we continue to do this and don't have to do as much prep work. But I think we had, for the panel, we had maybe had about 20 minutes or so. So that was definitely not enough time. And we had a lot of questions that we had already prepped. So then we barely got through those, and didn't really have much time for the Q&A. So, I mean, depending on how things go and where you are in the series of equity rounds that you develop, you could do different amounts of time. But I would say, hour minimum, but it was tight for our first time.
And if I can add, we've kind of already adapted that process too. So this Thursday, I mentioned we're having our next Health Equity Rounds event. So we have an external speaker coming in to give our grand rounds in the morning about a health equity topic. And then we decided to have a second Health Equity Rounds event later that afternoon to give enough time for conversation and questions that people want to ask and have answers to. You don't always get the answers, but at least you have a forum to kind of discuss and process the grand rounds from the morning. So we're hoping to see, I don't want to say better results, because I think we had great results from the first one, but hoping that people feel like they had a little more time to personally connect with things and discuss and ask questions. Another question online from Cecilia. When significant issues of equity are identified, how efficiently can changes be implemented to address this inequity? What are the barriers that cause delays in implementing these changes?
Thanks for that question. That's another great one. Well, there certainly are barriers to implementation and addressing health and other inequities. And so I think none of us were under any illusion that health equity rounds would be something that would immediately mitigate the equity issue that arose in this case. Yet we felt it was still something that was really important to talk about. To take a step back, we do within UW Health and the School of Medicine and Public Health, there are multiple forums that folks can use to discuss equity issues when they feel like either they themselves have experienced an event, there's been an event that they witnessed at work or whatnot. And so to some degree, we discussed that those were options for folks who were participating in the audience for health equity rounds if that brought up some of the, it brought up issues for any of them. But I think we've all taken, in terms of the big picture, we've taken the philosophy that that we're just going to keep chipping away, one step forward, and each opportunity we can, and that we felt it was, I think, especially critical to have a forum to air our own dirty laundry around a health equity issue that happened in our children's hospital that really hit very close to home.
Besides reflecting post-incident, are you going to be requiring any mandatory equity training for physicians and staff?
I can take that one too. Oh, this is an area of much discussion. Historically, there has been a lot of hesitancy to mandate training on this topic for a variety of very legitimate reasons. We want to make sure, and I say we, not me specifically, but kind of collectively, it's very important that when health equity work is rolled out, that it's done so in a systematic fashion using evidence-based techniques that help to mitigate harm. I think there's definitely been some concern that one-off computer-based learning training modules is not going to be an effective way to actually impact health equity for our patients and families, and equity just in general in the workplace and in life. So I think it's certainly been a topic. There are multiple different training options within our health system. But at this point, there has not been anything that's been specifically mandated, although it's something that we're definitely discussing and potentially thinking about incorporating in like orientation for new employees, so that we can just kind of set the stage right from the get-go in our department that this is the environment in which you work, and we don't tolerate racism, et cetera. Hope that helps.
I was just going to add that our department has several strategic priorities that we've developed over the past several years, and DEI is one of them. And so we really, I mean, Mary is our DEI director, but I think as a department as a whole, we've really tried to layer on the different opportunities to become aware of our own biases. And so there's a variety of different things. And speaking from professional development, we have opportunities to learn. We had a session last year on how to address microaggressions, so this is something that happens not uncommonly in our workplace, and as a person who witnesses a microaggression or who has experienced one. So just kind of layering on the different opportunities, I think, is also really important, instead of just a one-off training or a one-off equity rounds, but really just thinking about how we can create a whole culture in our own department or division.
I think we have time for one more question before our last slide here. Is the hospital now keeping data on security involvement by race?
I think we'll have to get back to them on that question. We do not know the answer.
Thank you. Okay. So before we end our session today, we would appreciate it if you all took a quick second to take our post-survey. It's almost exactly the same as the pre-survey, with just a few extra questions at the end. There's also an opportunity for you to put in your email address. We'd love to follow up with you and your equity rounds journeys in your workplace, if you'd like us to. So if you're interested in kind of us checking in with you in 6 months or so, we'd appreciate if you put in your email address for that section.
I just wanted to say one more thing before you go. From the time we heard about health equity rounds to the time we were able to have our own was about 6 months. So it didn't take a long time to implement. So just so you can be encouraged by that.
And as you're filling out that post survey, we want to give you all a big thank you for joining us today and asking your great questions. Please reach out to us if you are implementing an equity rounds or have any questions. We would love to support you and help you and give you any resources that you need. So feel free to take a picture or find our contact information on our slides on the Diversity Forum website. And thank you.